Good afternoon, everybody. Welcome to today's Checkerboard chat. We are so pleased to welcome Dr. Leslie Hamilton with us today. I'm going to introduce Dr. Hamilton really briefly, and then we are going to send it over to her to get started with our talk today. Dr. Hamilton is the Associate Professor of Clinical Pharmacy and Translational Science at the University of Tennessee Health Science Center College of Pharmacy. Dr. Hamilton has received multiple awards, including the Most Influential Professor, Distinguished Young Pharmacist, and the Excellence in Teaching Award. She is also a Fellow of the Society of Critical Care Medicine and the American College of Pharmacy. And lastly, something I completely forgot to mention, Dr. Hamilton, is a most recent Volunteer 40 Under 40 award winner. So we are so excited to have you with us today. I'm going to go ahead and send myself away, but I do want to let our audience know that you can ask questions throughout today's chat. You can just actually insert those into the comment section, and we can pull those in towards the end of our talk today. But I'm going to go away. I'm going to send it over to you, Dr. Hamilton. Thanks so much for being with us today.
Thank you, Jordan. Well, it was so nice to hear Rocky Top, and I can't believe our first football game is coming up this Thursday. It's already hard to believe that this season's getting ready to get started. So thank you for the wonderful introduction. And as Jordan said, I am a pharmacist, both a pharmacy faculty member for UT Health Science Center College of Pharmacy, and I also practice in neurocritical care. So this is kind of my introduction. And I will tell you some of the things that I'll be talking about today are really my opinion and don't necessarily reflect on UT Health Science Center, UTK, or UT Medical Center, but I'm going to be sharing some data with all of them. Jordan, you can go ahead and advance to the next slide. So to give you guys a little introduction about myself, I have mainly lived and practiced in the Southeast, and I am a proud 2003 graduate of UTK, and I actually have a bachelor's in English literature, minor in history, and I did my pre-pharmacy studies at UTK. So I started there in Knoxville, where you see that gold star, moved to Memphis for pharmacy school. So that's when I went to UT Health Science Center for my 4 years of doctoral training in pharmacy. Did my first year of residency at Moses Cone Hospital in Greensboro, North Carolina. So moved to North Carolina, back to Memphis for my second year of residency in critical care at Regional One Health. It was called the Med when I was there as a resident, but now it's called Regional One Health. Moved to Auburn down the branch that's in Birmingham, Alabama. Worked for Auburn University's Harrison School of Pharmacy for 3 years. And then since 2012, I've been back in Knoxville, teach at UT Health Science Center's College of Pharmacy in Knoxville. And then I also practice at UT Medical Center, which is across the street from where I am today in my office on campus. So my true love is the Volunteers. Go Vols. I'm so excited. I will secondarily root for Auburn since I did used to work for them, and they are, in our SEC. But this is kind of where I've been in my journey in terms of my training, where I've taught, where I went to school. And so I'm a proud double graduate of both UTK and also UT Health Science Center. So the first thing that we are going to talk about today, so when Jordan asked me to potentially speak this fall, I told him there were kind of two things that I would probably feel prepared to speak about. One is about the COVID-19 pandemic and what it's kind of been like working during COVID-19 in the hospital. And then also about stroke. So I am a very passionate pharmacist who practices in neurocritical care and take care of a lot of stroke patients. And so there's some things that I want to talk to you all today about in terms of preventing stroke. And then when someone has a stroke, how we treat stroke when someone comes to the hospital. So these two images are pictures of me in the past 15 to 18 months with my N95 on in the left and then a hairnet to keep myself safe. And then also goggles, glasses, and also mask. And I'm in my scrubs in both of these places. So I really have to thank, all of the other healthcare providers. Me as a pharmacist, yes, I am practicing in this setting. However, there are so many other pharmacists, nurses, physicians, physical occupational therapists, so many different people who are taking care of these patients. And as you can see, you end up wearing a lot of garb and it can get kind of warm, but these are some pictures of me kind of throughout the pandemic and some of the things that I have been wearing. So Jordan, go ahead and on to the next slide. So I know if you're like me, you are tired of hearing about COVID-19, and me, just like any of the rest of you out there, wishes that this pandemic, that A, never started, but B, was over. And going through the Delta wave right now has really put a large burden on our healthcare systems, both on the outpatient setting and also on us in the hospital. So the first few things are, I want to kind of for you to think about how you can prevent COVID-19, how you can be safe out there. And then also if you do get COVID, and hopefully you don't get it, if you do get it, it's not very serious, how you're able to manage it at home. Now, living in Tennessee, and I'm sure some of you all out there also live in Tennessee, though I know you all may be, all over the place. Our guidelines, it's felt like they have changed a lot, and especially towards the beginning of the pandemic. I think one of the most exhausting things as a healthcare provider that I have noticed is that the rules or the guidelines or the guidance has changed, and it has changed very frequently. At the very beginning in March 2020, we were supposed to save our masks for healthcare providers and for the hospitals. And part of that was because we didn't have enough supplies for our hospitalized healthcare hospital healthcare providers to be able to safely take care of patients. And so that was our beginning, kind of guidance. Then it moved to, yes, you do need to wear a mask. And then guidance kind of changed from the CDC if you were vaccinated or not vaccinated. And now it's changed back again, whether you're vaccinated or not, and how important it is to wear a mask. So like many of you, I keep my mask very close by. Working in our College of Pharmacy, masks are required both in our pharmacy school and also in the hospital. So I do get a lot of use out of masks. Something that's very important is staying at home when you are sick. So even if you may have what feels like allergies, or you might have something that feels like a cold, it's still important to stay at home and not go to work. And I'm kind of one of those people that if I was feeling, had cold-like symptoms, then I would, think, okay, I'm fine, I can go to work. The thing is, we don't know if those cold-like symptoms are actually COVID. Now, it's important to get tested if you think that you might have some sort of COVID-like symptoms, or there's even some home tests now. Binax, which is one of the companies that makes one of the home tests, does have those available that you can test at home. Avoiding contact with people who are sick. And, I really feel like this is great advice for anyone, really anyone who is going through all the stress of the pandemic, is trying to get enough sleep, trying to eat well. And so trying to do those sorts of things, washing your hands, especially after you've touched common surfaces like door handles, light switches, that sort of stuff. Wearing a face mask when you're going out in public. And I do not enjoy wearing masks. I don't think anyone enjoys wearing masks. The thing is, though, we need to be as safe as we can to protect ourselves, and especially some of the ages and populations who are not able to be vaccinated. So kids less than 12 years old. And there's also some literature in people who are immunocompromised, maybe have had a transplant, maybe are undergoing chemotherapy, maybe just have some risk factors and they're older. Just it's our duty to help protect our fellow citizens and making sure that they're staying safe. I know many of you may struggle with this. Sorry, Jordan, if you'll keep on back on the last slide, I'm going to spend a little time on this. I know some of us, really struggle not to, scratch our eyes and touch our nose and our mouth, and really trying to do that. And then also disinfecting high touch areas. And thank goodness Lysol and other types of disinfectant things are more available than they were earlier in the pandemic. And then as well, if you have COVID-like symptoms, making sure that you let your doctor know, or urgent care, wherever you're going to get tested or seen, that they know that. Now, on the left-hand side of this slide is if you do have COVID, and hopefully you are vaccinated or have a very mild case of it, stay home unless you need to get medical care, getting rest and making sure you're staying hydrated, talking with your PCP, and they can help manage some things from home. A lot of the same things that I just covered on the right are also apply on the left as well. Keeping things clean, don't share drinks or utensils and that sort of stuff. And if your symptoms do get severe, and hopefully none of you experience that or have experienced that, is making sure to keep an eye on your respiratory symptoms. That's where we see people get into trouble and have to be admitted to the hospital. And so they have things called pulse oximeters that you can buy at a pharmacy or a grocery store, and can keep an eye on your oxygen status if you do have COVID. But try to stay out of the hospital if you can. If you have, even though it may feel very severe to you, if you are not severe enough to be hospitalized, and that's actually a mild case of COVID, unfortunately, because the people that we have admitted are not able to keep their amounts of oxygen in their blood up at a good level unless they have oxygen either on their nose or on a face mask or through the ventilator. So those are just kind of some things to think about. Something that I know that I've taken advantage of during the pandemic is either delivery of things or also pickup. And I pick up my groceries when I'm getting groceries. I did this before the pandemic, but it can be a very helpful thing if you really can't get out to have, if you're able to, groceries delivered, or maybe pick up groceries if that works for you. Okay, Jordan, you can go on to the next slide. So I am a big proponent of vaccination, and I am not here to shame anyone today. I'm just here to provide information and making sure everybody has all the research and all the information that's out there. So in the United States, we are lucky enough to have 3 vaccines: the Pfizer, the Moderna, and the Johnson & Johnson or the Janssen vaccine. And they've all been shown to be safe, effective, and also reducing our risk of having severe illness. Now, many of you all have heard on the news fairly recently, within the past week or so, the Pfizer vaccine, which was the very first vaccine that came out in the United States, it now has full FDA approval for ages 16 and up. Now, it still has that emergency use authorization between ages 12 and ages 16. And as they're getting more data in that age group, then they expect very soon that we'll have full approval for the Pfizer vaccine. Moderna has already submitted all their information to the FDA to have full approval coming for that. And then same thing with the Johnson & Johnson vaccine, the approval's coming. Now, a few things to know about it. Right now, Pfizer has the most data into the youngest age groups, 12 years and older. And also, there are trials going on right now with younger patients less than the age of 12, that hopefully means that very soon, hopefully this year, but we'll see kind of what happens, that younger age groups of kids will be able to get the COVID vaccine. Now, with the Pfizer vaccine, it is 2 vaccinations, 3 weeks apart, so approximately 21 days. For the Moderna vaccine, it's 2 shots that are given 28 days apart, or about a month apart. And then finally with the Janssen one, it's a 1 shot and it's a one and done. And I have some personal friends who I know who hate getting vaccinations and hate seeing needles and that sort of stuff. So that's, if you're in that category, then this might be a good shot for you. Now, a few things to think about is you're not considered fully vaccinated until 2 weeks after any of these series or single shots, depending on which one that you get. And another thing that's important to know is I think that we forget that vaccinations, these vaccinations are very, very effective. However, they're not 100% effective. In clinical trials, the Pfizer and the Moderna were about 93 or 94% effective in preventing very severe COVID. But it doesn't completely prevent all COVID. It can still happen in patients. And as there's been stuff in the media out recently, especially for the Pfizer vaccine, for patients who may be immunocompromised, like have those disease states like cancer, transplant, something like that. They're eligible, if it's been 8 months since their first series of the Pfizer, that they're eligible for a 3rd dose. And hopefully for those of us healthcare providers and maybe older patients who got immunized more than 8 months ago, then hopefully this will be coming for us soon. These vaccines are fantastic. They have, the Pfizer and the Moderna are mRNA vaccines, and that technology has been out and has been studied for 10 to 15 years, though it's just been recently applied to this application for COVID. But the technology is not new. And I know some myths that I hear is, oh, the vaccine was rushed. I think part of the reason that we got this vaccine so quickly is we have never had the world working together, and also the amount of money that so many countries provided to these researchers. We've never had that happen before. So this is why these vaccines were faster than we're used to, because of that ability of all the scientists, all the cooperating countries working together to have this out to the general public as quickly as they were able to. So that's something that our governments all over the world have really helped with. But remember, the big point is get vaccinated. It's your best protection against COVID-19, best way to stay out of the hospital. It's best way to stay as safe as you can. But do remember, the vaccines are not 100% effective. And so there's still a chance of getting COVID even if you are vaccinated, because they're not 100% effective. Okay. So Jordan, go ahead and go on to the next slide. So as I mentioned, I practice at UT Medical Center, and for basically the entire pandemic, we get a daily dashboard, and they've just been starting to share this on social media. UT Medical Center has. No matter what state or city you might be in, hospitals across the country are sharing data like this. And I think this, especially the trend, and it's gotten even worse in the past few days since I pulled this dashboard, it's getting worse. And those of us who are practicing in healthcare facilities, we are seeing so many patients with COVID. But the part that worries me even more than COVID is the other patients that we are having problems taking care of, not just at UT Medical Center, any hospital in the country, because I practice in stroke. And if we have an outside facility, a smaller hospital, as a patient with a stroke and they need higher level of care, we may not have a bed for that stroke patient because we have so many beds that are being taken up by COVID patients. Another thing to think about too is, car accidents, people having a heart attack. There's so many different things that people can have besides COVID, and the burden on our healthcare system as a country and really throughout the world is because so many of these resources are being utilized by patients with COVID. It's really putting this large burden on our healthcare system. And I notice, I've talked to some of my family members, and they're like, well, we just need more beds, like if it's a bed issue. But when you hear someone say bed, that also means a physician that's taking care of that bed, a nurse that's taking care of that bed, a pharmacist that's taking care of the medications for that bed, and all the other staff that help take care of those patients. And so those are things. It's more than just a physical bed itself. It's a lot of things that go into that. Now, I'll tell you that right now, our vaccinated versus not fully vaccinated status at UT Medical Center is about 85% of our inpatients that have COVID-19 are not fully vaccinated. This means both vaccines with Pfizer or Moderna, or one vaccine if it's Johnson & Johnson. 15% are fully vaccinated, and you can notice and see the mean and the median percentages in terms of ages over here on the right-hand side. And this population is younger than it was in the earlier phases of this pandemic and waves of this pandemic, where the average patient might be 60, 70, 80. Now it's 30, 40, 50, and it's a lot lower. I mean, we have 20 and 30-year-olds who are very, very sick. And at least the most recent data that I've heard, at least at my hospital, there is no one who is requiring to be on the ventilator who has been fully vaccinated. There are some people in the ICU, but no one's on the ventilator has been fully vaccinated. So that I think the data and the curve can speak for itself. It's so important to get vaccinated. Okay, Jordan, you can go on the next slide. Now, this is how to prevent COVID. Now we need to talk about what happens if you get COVID. And I just want to make sure everybody has all of the info that's out there. And then also, when I get to the next slide in just a few minutes, it will be how we treat someone if they're in the hospital, okay? So outpatient treatment, a lot of it is symptomatic treatment, like you might have if you have an influenza, if you have a cold, something like that. And you might be taking things like Tylenol or something like Motrin to keep your temperature down, drinking a lot of fluids, making sure that you're doing the best you can for that. Now, for patients who might be at a little bit higher risk, there's something that's called a monoclonal antibody, and there's two that are approved. Casirivimab and imdivimab are a combination of therapy, and then sotrovimab is another option. And the more common one is this is made by Regeneron, and you may have heard that in the news. This combination one right here. I have, in terms of the links here, I have some info from the state of Tennessee and also from the National Institutes of Health, which is our national part for the United States. Some info in this, and I think it's kind of cool. One of the monoclonal antibodies was basically based on someone who had SARS, which is SARS-1. Right now we're going through SARS-2 or COVID, and they has this spike protein that basically can help people quickly fight off COVID. Same thing with the combination. It's a different way that it was made, but spike protein. And so for people who are at high risk for getting very sick, and I'm talking about, and it doesn't matter if you're vaccinated, you can still get these infusions if you get COVID. I'm talking about people who are over the age of 65, people who are morbidly obese, people who have diabetes, people who might be undergoing treatment for cancer, like getting chemotherapy, or maybe have HIV or have had a transplant. There's a lot of different things that go into the decision about who qualifies for monoclonal antibodies. Now, kind of exciting news, in the past 2 weeks or so, it's been approved, the use of the monoclonal antibodies has been extended now for people who are close contacts of people who have COVID. So maybe your spouse has COVID, and you, of course, have been a close contact. You live in the same house, and you're trying to stay away if you can, but they also have some literature that this might be helpful in people who might be at high risk, don't have COVID themselves, but they've been closely exposed to it in the very recent past, and they may be at benefit for these. Now, I know a lot of hospitals, I'll speak in the Knoxville area, most all the major hospitals in Knoxville are doing this. There's a lot of outpatient clinics who are doing this. So I don't know that our government, our states, we as healthcare providers have done as good enough job as we could have in emphasizing monoclonal antibodies, but they're out there. Know that they're out there, and if you do get sick with COVID and you do qualify for these monoclonal antibodies, just know that they're out there, and it requires a physician referral. It's either an infusion or a subcutaneous injection, but your physician or healthcare provider can tell you more about that. Okay, Jordan, go on to the next slide. So as Jordan is going to the next slide, what we'll talk about in just a minute is we'll talk about the other options that we have for inpatient treatment. Now, I don't want any of you to come to the hospital if you don't have to, because we do not have great options. We don't have, if you get strep throat or a sinus infection and we have an antibiotic that's very narrowly targeted to treat that infection, we don't have as good of drugs to actually treat COVID-19. So this is kind of our algorithm at UT Medical Center, and it's very similar to algorithms at hospitals across the country. So if someone's admitted but they're not having any oxygen on, like through a nasal cannula, then the guidelines, not only our guidelines at UT Medical Center, but guidelines based, this is national guidelines. They recommend against the use of dexamethasone or another corticosteroid unless there was another indication for it besides COVID. There's also insufficient evidence to recommend either for or against remdesivir, which is one of our other options that we have. It may be appropriate for certain patients at high risk of disease progression. Now, if a patient is on supplemental oxygen, and this is not only that they might be on oxygen at home and they're requiring more oxygen in the hospital, but these are anyone who's having, is also requiring new oxygen in the hospital. We have really kind of two options. We have remdesivir and we have dexamethasone, and depending on how severe somebody is, then you can use them in combination, or if there is a contraindication to one of these medications, then you can use them by themselves. Now, I'll tell you, remdesivir, there's a lot of monitoring parameters, and me as a pharmacist, what one of my jobs is, if I have a patient who's on this, I have to watch their liver function test, I have to watch their kidney function, because we have to adjust or maybe hold those doses if those things do get worse. So those are things to watch for. Dexamethasone is not benign. It's not without its own issues. We use dexamethasone for a lot of reasons, even besides COVID. It's an anti-inflammatory steroid agent, but it can make patients' blood sugars go up. It can delay wound healing if somebody has had like a surgery or something like that. So, we really don't want to have to use these agents unless we have to, unless a patient is severe enough. Now, the oxygen that's through a nasal cannula can be kind of upgraded to a higher flow, that there's more pressure that's that's allowing more oxygen to go in. NIV is non-invasive ventilation. So if any of you wear a CPAP mask at home at all, that's kind of like a CPAP or a BiPAP mask. It's a full face mask that a patient wears. And then they can get remdesivir and dexamethasone in those cases. Now, where we really don't want to see you in the hospital, we want you all to stay safe and be able to stay at home, is if someone requires mechanical ventilation, which requires a breathing tube down someone's throat. Dexamethasone is definitely recommended in these patients. And if someone isn't sick enough to be in the ICU, there is a drug that's used for other disease states. We've kind of repurposed this drug and found that it may help in some people with COVID, is tocilizumab. And that drug really helps with what's called a cytokine storm. So basically, if your body gets really, has lots of inflammatory markers and someone's really, really sick, and you have all these cytokines being released from your immune system, it can kind of help in those situations. Also not a benign drug, has its own risk of side effects. So these are things, this is, if you've never heard how we treat someone on the inpatient side, this is the things that we have. But like with some other disease states where I might have like 10 different options to offer a patient, we have very little, unfortunately, that we're able to offer. Not because things haven't been studied. There have been so many things that have been studied for COVID-19. However, these are the things that are found to have the most benefit in the clinical trials that have been published. Okay, Jordan, you can go on to the next slide. This is where I don't want to see you. And in case you've never seen pictures of this, I promise these are pulled from the internet. They're not real patients of mine, but I pulled pictures from the internet just for purposes of explaining this to you all. This is an example of what a breathing tube or an endotracheal tube looks like, and this same with this patient right here. And the breathing tube goes down when it gets inserted. It goes down kind of under your tongue all the way down into the trachea, and there's a little balloon right here that gets inflated to make sure that the ventilator and the tube are working appropriately. It's not comfortable to have a breathing tube in your throat, and that is the goal, is to not have that happen. Now, if people get very, very, very sick, we have a very limited availability, not just at UT Medical Center, but at a few centers across the state of Tennessee and around the country, called ECMO. ECMO is extracorporeal membrane oxygenation, and it's a machine, which is up here in the right-hand corner, that can help take your blood. It's kind of acts like a heart and a lung for you if your heart and lungs aren't working like they're supposed to, and it can help give oxygen to the blood when your body is not able to do it itself. Now, this is a very scarce, limited resource. For example, we only have 2 or 3 machines at UT Medical Center because it requires so much staff to take care of these patients, and it's such a resource and time-intensive thing for patients. I know Vanderbilt, various other centers across the state of Tennessee do have the capability for ECMO, but unfortunately, as you may have heard in the news, especially I remember hearing this in California and out west, there's waiting lists for ECMO, and ECMO doesn't cure everybody, but it's kind of a last resort if people get sick enough and they are not able to oxygenate their blood on their own. Okay, Jordan, go ahead and go on. So we'll stick on this slide for just a second. So we're going to switch topics in just a minute, but things that I really kind of take home pieces for this is please get vaccinated. Please stay safe, keep your hands clean, wear your mask, all the things that you can do to help get this pandemic to end, because we are all tired of this pandemic and so tired of hearing news about COVID-19. So thank you for listening to this portion. Now we're going to transition over to stroke prevention and treatment, and I'll also tell you how this relates to COVID-19. So go ahead and go on to the next slide, Jordan. Now, unfortunately, COVID-19 does cause strokes, and I've had on my inpatient ICU service numerous patients, unfortunately, who've had either an ischemic or a hemorrhagic. So that's the kind of blood clot type stroke or the bleeding type of stroke that patients can have. COVID-19 is a nasty illness, and it can do so many more things than just your heart and then your lungs. It can also infect your brain. So I love educating about stroke and having people be the safest that they can. And if they see stroke-like symptoms in a patient, in a loved one, in anyone, the little acronym from the American Heart Association is B FAST. So B is for balance. So if you see someone is dizzy and is feeling kind of discoordinated or uncoordinated, then that might be a sign of a stroke. So if their vision is all of a sudden blurry and it's not normally blurry, that can be a sign. If you ask someone to smile for you and you see one of the sides of their face drooping, that can be a sign of a stroke. If someone puts their arms out, I know it's kind of hard for you to see my arms, and an arm is drifting and they're not able to hold their arms up together, that can be a sign of a stroke. Slurred speech when people are talking. And the most important thing is to please call 911 if you or a loved one, you think that you or a loved one is having a stroke, because we do not want anyone to drive themselves to the hospital who might be having a stroke, because they can get in a car accident, and getting by ambulance is the fastest way to get treatment for a stroke. Okay, go ahead, Jordan. So what can you do to help prevent a stroke? So we're going to talk about prevention, and then we'll finish up with the treatment of stroke. So if you have a high blood pressure, hypertension, if you have diabetes, if you have high cholesterol, really, really work with your physicians, your nurse practitioners, your physician's assistants that you work with, and keep those things down. Keep your blood pressure at a good level, keep your glucose at a good level, and really make sure you're taking your medications for those disease states. If you're a smoker, please stop smoking. It not only causes lung cancer, but can also cause stroke. If you are not as physically active as you ought to be, really getting out there and getting physically active, and also losing weight, even a 5% weight loss can have a huge benefit for less risk of heart attack, stroke, and all those sorts of things. And so they really recommend 150 minutes of physical activity a week. And it can be walking, it can be yoga, it can be whatever sort of class that you might want to take. And really, try to get fruits and veggies in and avoid, even though it's easier, avoid some of the fast food options because just they're not as healthy. And that there is literature that says that up to almost 80% of patients who have strokes, almost 80% of those are preventable. So let's do our part and stop stroke if we can. Okay, Jordan, go on to the next slide. So this is an image that I use for my students when we talk about stroke, my pharmacy students. So what an ischemic stroke is, there's two types of stroke. One is a cardioembolic. Cardioembolic means from the heart, and it causes an embolism that goes up to the brain. And so that is what a cardioembolic stroke is, and it kind of goes up and causes a blockage in one of your brain blood vessels. Another type of stroke is a plaque rupture type of stroke. So this can happen in patients' carotids a lot of times, or in the vessels in the brain, that there's plaque that forms just from years of high cholesterol and other things, and a piece of that plaque ruptures off and then causes a blockage, and so then blood supply is not able to get to a part of your brain. Now with a hemorrhagic stroke, there's two types. There's an intracerebral hemorrhage, which means part of the vessel wall gets weak and it ends up causing a bleed. What can happen in this case is if people have high blood pressure that's not well controlled, unfortunately, this can happen and cause a head bleed. And then finally, there's also an incidence of patients who have an aneurysm that can rupture and then can cause a subarachnoid hemorrhage. Okay, go on to the next slide, please, Jordan. So if someone has a stroke, in case you have never known this before, I'm going to talk about what happens if you call 911 and you come to a hospital. Is, the paramedics will respond to wherever you are. They send us a notification via pager. So I get a page that tells me about a stroke that's coming in by ambulance. There's a whole group of people that meet this patient and family members down in the emergency department. We do a scan of the patient's brain. And depending on what we find, we can give a clot dissolving medicine, or we can do endovascular treatment. And that is basically where you go in. I know this is a kind of a very simplistic way to describe this, but I describe it as if any of you have ever used a snake in a drain before, and you've used a snake to get a clog out of a drain. It's kind of the same principle, much more, of course, technologically advanced, but then they'll go up inside of your brain and use a catheter and then pull that clot out. After someone has had those therapies done, you can have one or the other or both. They will go to acute stroke unit and then eventually to rehab. So you see there's a whole group of people who take care of these patients. Here's me as a pharmacist, nurses, physicians, all our different therapy colleagues, social work, dietitians, physiotherapists, that's physical therapists, psychologists. There's so many people who take care of these patients. So this is kind of the general workflow, the general flow of a patient. If someone is having stroke-like symptoms, they get brought to the hospital. This is kind of what happens to them. Okay, Jordan, go on to the next slide. Now, there are two in the United States. There are two agents that are used for treatment of stroke. Alteplase, or TPA, is listed here on the left, and then tenecteplase, or TNK, is listed here on the right. TNK has started to be used more frequently in the past year or so because it's been shown in some trials that it may be more effective than TPA in certain patient populations. So certain hospitals have switched and they're using tenecteplase instead. What my job as a pharmacist, when I respond to a code stroke, I work with the physicians and the nurses there, making sure a patient qualifies for this, making sure they're in the right time window, making sure they're not taking any medications that would prevent them or preclude them from getting this medication. Then I actually mix it, prepare it in a sterile environment, and then have it ready for administration. And our goal is to get this medicine in you as quick as possible. We have a time crunch, because the time is brain, and so we want to save all the brain cells that we can for our patients coming in with stroke. But these are kind of pictures of our different agents that we have that we can use to thrombolysis. All that means is to lyse a thrombus. Lysing means just break up a thrombus if someone has a stroke. Okay, Jordan, go ahead and go on to the next slide. Now, I'm going to pretend you all are in pharmacy school for just a minute, so to kind of show you how it works. And to me, a picture is worth 1,000 words sometimes. So if you see all these platelets together, that they're in a vessel, and then everything's binding together, and then if that happens, then blood is not flowing through that vessel like it's supposed to. And what TPA, alteplase, tenecteplase, T&K do is they are fibrinolytics. Lytic meaning break, okay? So they break up the bond, and they work binding to plasminogen, go to plasmin, and they cause this lysis of these clots. And so it's awesome. You see there's a clot there, and then all of a sudden it starts dissolving, and all of a sudden the patient, maybe they're not able to speak, they can talk again. It's a really, really cool thing to watch. Now, this drug is not without risk, and it has very certain criteria about who can get it. Those are things that are important, and, to think about when when I'm thinking about what treatment options do I have for these patients. This is kind of how TPA works. Okay, go ahead, Jordan, to the next slide. Now, I also want to show a picture of this, because to me, this is one of the coolest. This is a really cool technology. We have physicians who go through a lot of training to be interventional radiologists or interventional neurosurgeons, and they go in and they have a catheter that goes up into the vessels of your brain, go through the clot, grab the clot, and pull it back out again. So it's a really cool process to watch. And patients, oftentimes, if they qualify for this type of therapy, then they almost have very little residual stroke symptoms because of the success of this technology. So, there's hospitals, in Knoxville, there's 2 hospitals, Fort Sanders and UT Medical Center, that both offer this type of therapy. Not every hospital does. And so if you're in a smaller community, then you might hear about being transferred to a bigger stroke center to help treat these sorts of things. Okay, go ahead, Jordan, to the next slide. Now, I think this is my last slide, and then we'll have time for questions. So what happens if you have a stroke? Just like with COVID, it happens, things happen, you need to know how to treat it. So even if someone has a transient ischemic attack or an ischemic stroke, transient ischemic attack are symptoms that are stroke-like symptoms, but they need to be treated just like a stroke, because that means that's a warning sign that a stroke is coming. Doing what you can do as a patient, losing weight, stop smoking. If you drink a lot of alcohol, reduce the alcohol intake. Keep your blood pressure less than 140/90 or 130/80, depending on what your physician's target is for you. Keeping your bad cholesterol or your LDL as low as you can. And then for those of you with diabetes, making sure you're keeping your glucose under control. Now, if someone does, these are other things that we can do as patients, is to try to do these things and do the best we can. There are drugs that are called antiplatelets. Some examples are clopidogrel or Plavix, aspirin, aspirin and dipyridamole, and that's Agrinox. There's another drug called ticagrelor or Brilinta. All these drugs can be used for stroke after someone's had a stroke, sometimes in combination with each other. And it kind of depends. If patients have the plaque type strokes, you're going to see patients, or those of you maybe, on antiplatelet drugs. If someone has the cardioembolic, and this is especially atrial fibrillation, so if any of you have atrial fibrillation, where your heart kind of does a weird quiver thing, and it causes blood to pool in the heart, and then it causes emboli or clots to kind of shoot up from the heart. Then there are things like warfarin or Coumadin, the DOACs, things like apixaban or Eliquis is an example of that. And there's some other surgical therapy depending on what all might happen. But if any of you are taking these sorts of medicines, or have a family member or a friend who's had a stroke, you're going to see targeting, high blood pressure, high cholesterol, high blood glucose, and then also treating the cause of the stroke, like if it's plaques that's built up, or an atrial fibrillation, using those sorts of things. Okay, Jordan, you can go on to the next slide. I think that might be my last slide. So, I really appreciate all of your attention. I know you all are in virtual land right now, and I can't see anybody. But I do have at least 1 or 2 questions that I see that I've gotten from Jordan that I'm going to answer. So,
and Dr. Hamilton, I did want to interrupt you just briefly. We had a couple of other ones come through in the chat as everything wrapped up. Would you like me to start with those first?
Sure. And I can look and look at them. Okay. Do you want me to just go off of them?
And I can throw them on the screen so we can have it.
Throw them on the screen.
Okay, we'll start with Donna's question here.
Yeah, so Donna, you ask a fantastic question, and thank you for tuning in today. So can clot busters be used if a patient has had an anaphylactic reaction to NSAIDs and aspirin? That's a fantastic question. And yes, they can be used in those patients. So the chemical structure of aspirin and of NSAIDs is different from the drug, the clot busting type of drug. And so that's information that I gather as a pharmacist, that I look and see and make sure, see if anyone's is on those agents or had an issue with those agents. But luckily, we can use those completely if no problem at all. If someone has had a reaction to aspirin or an NSAID, no problem.
Perfect. Thank you so much. And we got a couple more here, so we'll jump into Jane's question.
Jane, that's also a fantastic question. Thank you for asking. What are risk factors for a stroke? So some of the things these are called modifiable versus non-modifiable risk factors. So non-modifiable risk factors might be age or someone's gender, that you can't modify those things in terms of risk factors for stroke. Modifiable risk factors are things like stopping smoking, losing weight, having a good diet, and keeping blood pressure, cholesterol, those sorts of things under control. So then that way we can try to prevent stroke. So those are some common things when we counsel patients who may have some of those either habits or disease states, and we really work with them to try to stop those or improve those, and really work with your physician and your outpatient providers to kind of prevent those things. So great question, Jane. Thank you for asking.
Got a couple more if we're good to keep going. Are you good for me to keep throwing them up here for you, Dr.? Okay, perfect. So next one here.
So Hannah, yes, there are a few types of strokes that may be hereditary. So in terms of the bleeding type of strokes, the aneurysms that cause subarachnoid hemorrhage, they often run in families. And so that is something that if you have had a loved one, especially a first degree relative like a mom, dad, brother, sister, something like that, who's had this happen, they can do a scan of your head to make sure you don't have aneurysms as well. And those can be fixed if that is something that is in your family. Some of the other types of strokes, like the ischemic strokes, they're not necessarily hereditary in terms of genetics, but I will say people who parents may have high cholesterol or parents who might have heart disease and high blood pressure, that is often seen in the kids. And so even though the stroke itself is not hereditary, some of the causes of the stroke may be hereditary. So yes, those are things that you can do to help prevent a stroke.
We have another question here from Dave that looks like we might be able to help guide him with some information here.
Yeah, absolutely. Dave, this is a common thing that I have. So I see Dave said he had carotid dissection and a patent foramen ovale, or PFO, and experienced a stroke about 21 months ago. Of course, work with your own physicians, but I'll tell you in general kind of how we approach these patients. Depending on a patient's risk factors, a PFO is a hole that's between the top chambers of the heart, both of your right and your left atrium. There's a hole there. There are abilities to patch that. There are devices that can close that hole, or some physicians really recommend patients use medication like aspirin, maybe potentially even warfarin, to prevent strokes from happening with that. Now, carotid dissections, depending on what caused that, oftentimes they'll eventually start healing. Sometimes patients get stents put into those carotids to help that. So I would encourage you, if your physician or whoever you see hasn't addressed that yet, just ask, would I be a candidate maybe to have my PFO closed? Do I need to be on a medicine to prevent future strokes in the future? Those are fantastic questions, Dave.
Yeah, and Dr. Hamilton, we do have a few minutes left. I know that, like you mentioned, some of those questions came to you beforehand. If you'd like to address some of those, I'll kind of leave you back on the screen to address those, and then we'll wrap it up after you go through those if you'd like to.
Okay, I'm gonna look and see if there's any other comments that I'm making sure I think I've addressed everything. Lastly, I'll just say, this is not necessarily a question, is just to really reinforce like kind of as you guys have asked questions, how can I prevent a stroke? And so really doing everything that you can. And I know it's hard. It's hot outside. It's Tennessee, right? It's really hot outside. Like today it's raining in Knoxville because we have Hurricane Ida that's kind of coming through our area. But even if you are doing things in your home to maybe lift some weights, do a video where you're doing yoga or some sort of exercise, anything that you can do to really help get yourself in better shape, that's going to help you live longer and hopefully prevent strokes. I'll do a final plug for vaccines for COVID is please don't come to the hospital. We don't want you to be in the hospital. We want everyone to be safe and be at home. So if you haven't been vaccinated, please strongly consider it. My email, I think, might be available, but I can take questions in terms of vaccine questions. I know that can be kind of a heated topic, but as a healthcare provider, really do everything you can to keep yourself safe in the pandemic and hopefully get this pandemic to end. I think that's all I have. Jordan, any other questions that you have? Anything else?
No, I just wanted to point out that we have had a lot of people comment about just how great the talk was and informative. So I just wanted to again say thank you for giving us some of your time today. I know that you are a very busy individual also, so thank you for carving out some time in your schedule to give to our viewers. And this Checkerboard chat will be reviewable. It will live on YouTube and Facebook if you ever want to go back and watch it again, as there was a lot of important information in here. And if you do need to reach out to Dr. Hamilton or have any questions, you can always reach out to me and I will be happy to forward those inquiries on to Dr. Hamilton. So we would just want to say thank you again for your time. We really appreciate it. And we will see everybody very soon. We have more Checkerboard chats coming up in September. On September the 7th will be our next Checkerboard chat. So please be on the lookout at alumni.utk.edu/events for more information about that. Thanks again, everybody. Have a great rest of your week and go Vols.
Go Vols. Thanks, Jordan.
Thank you.